palliative care webinars. Thank you to all of you for joining. My name is Jo Hayes. I'm one of the palliative care consultants working with the UHW team, but it's my clinical nurse specialist colleagues who are going to do the presentation today. So I'm just going to introduce Andrea Oliver and Jo Gill, who are both palliative care nurses working in the UHW and Llandoch teams, who are going to go through a presentation and talk to you today. Questions in the chat, please, and we'll come to them at the end. And just a reminder to say that the webinars will be recorded and they'll be available for anybody who wants to watch again or who wasn't able to make it today, and that'll be on the Cardiff University YouTube channels. The links will be sent to everybody who was not able to come today. And then we will ask just for a quick evaluation at the end, so you can let us know how the webinar has gone. So yeah, thank you very much. I'm going to hand over to Andrea and Jo. Thanks.
Thanks, Jo. Hi. So my name's Jo, and good afternoon. Thank you for joining us for this presentation this afternoon on caring for patients at the end of life in the acute hospital setting. I think it's quite widely accepted that most people would prefer to die at home, or certainly that's what a lot of surveys say. And that's something that you hear a lot on the media. And I've certainly heard it from the health minister recently that most people would prefer to die at home. But a number of these surveys, they ask the general population about their preferred place of death. However, we are not dealing with the general population. We're dealing with people who are perhaps at the end of a long, arduous journey, which brings them to this point in their life. We're dealing with people that are vulnerable, that are very weak, and have had a lot of dealings with health professionals um, more and more as their disease progresses. Obviously, first and foremost, we want to give people choice to respect their preferred place of death. But actually, sometimes this may be the hospital ward. For example, people may prefer to die in hospital because they have young children at home and they don't want home to be a place of very sad memories. And in fact, if you remember Dame Deborah James, the lady with bowel cancer who raised all that money, she actually preferred to die in her parents' home rather than her own home for that exact reason, that she didn't want to die in the house where her children lived. There's also a lot of loneliness and isolation around at the moment. And actually, people, you can understandably, don't want to die alone. So the hospital, again, may be a preferred place to die. Other people that I've met also, they just have spent such a lot of time in hospital in the recent months that they really trust the hospital staff and they feel safe and would rather stay where they are than get moved to a home or the hospice or a nursing home setting. So that's what we're going to do today, is look at end of life experience in an acute hospital setting. First of all, we're going to look at a really very important question. How do we actually recognize when someone is dying, particularly when people have had lots of admissions where they've actually rallied, gone home again? How do we actually recognize that end stage? It's a question that we're often asked a lot about. Then when we've come to the conclusion that actually perhaps this is a terminal event, how do we manage patient care from then on? Andrea is then going to talk then about communication. Obviously, communication is always a really important aspect in all aspects of life. But she's going to look at very important points when we're in this situation. I'm going to then look at some considerations about the actual environment. Obviously, the hospital is a very busy, very noisy place. What can we look at in the environment to perhaps make it a slightly better environment at the end of life? And then finally, we're going to look at emotional support. Often we found that written, emotional support offered, emotional support given. What do we exactly mean by emotional support? So I'm now going to hand over to Andrea, He's going to talk about how to recognise the dying patient.
Oh gosh, sorry. Okay, just preparing things here for you. Here we go. Okay, so my name's Andrea. As Joe's introduced me, I work in the acute hospital setting, and we care for patients obviously dying in the setting on quite a regular basis. So my talk today is about recognizing the dying patient, you might want to just take a moment to have a think about a patient that you've come across in this situation. It might be somebody that you've cared for over a number of weeks or even a number of months in this situation, or someone that's actively and acutely deteriorated quite rapidly, and what little indications you picked up during this situation to give you the indication that things were changing and this patient might be approaching the end of life. So when we get our when we do our first assessment as palliative care specialist nurses, and we go to see these patients that we've had referred maybe for symptom management or end of life care, we gather all that information together, looking at their previous medical history, what's brought them into hospital, what their clinical signs and symptoms may be, whether they've got a chronic disease, whether they've got a cancer diagnosis, and just build up that picture of what's been happening at home and what they've been admitted with. We take into account their medical history, whether they've got a chronic condition and whether this has just started to change, maybe over a number of months or a number of weeks, and the clinical context regarding that. We would look at if they've got any underlying diagnosis, like a cancer diagnosis, and maybe look at any oncology treatment plan that's been in place for that. And we take into account person's goals and wishes, and for those that are important to the person about their future care. So we just building up the whole picture really of what's been happening at home, how things have started to change, what's brought them into hospital, and what is indicated that things might be not going in the right direction. So most importantly then, we look at reversing the reversible. Sorry, this isn't working. Sorry, my slide doesn't seem to be uploading here very well. So we look at reversing the reversible. Sorry. So we take into account any infections they might have, what their bloods are. Click on that. Sorry, I'm all new to this, as you can probably tell. So sorry, go back to that again. So we look at reversing the reversible. What are the causes that have brought that patient into hospital? And are there things that we could potentially improve, turn around, and then hopefully discharge home? So within the situation of palliative care, there's many reversible causes of that decline and things that we should be considering. And they come under quite a wide variety really of hypercalcemia, acute kidney injury, hypoglycemia, any infections, neutropenic sepsis, as we mentioned, if the patient's had chemotherapy, any side effects of any medicines, if they recently been started on analgesias and opioids, or any cerebral causes, maybe brain metastases, which would then respond to treatment regarding steroids and radiotherapy. I think it's important when we're talking about these patients, so we look at their underlying conditions. This slide isn't the best, I do apologise, but it's just to give you a bit of an idea about the disease trajectory that we take into account when we're looking after these patients really. The blue one on the left here is the cancer diagnosis, and when we think that those patients, given that terminal illness, how quickly we would expect them to deteriorate. And they might trundle along for some time, but they would have more of a rapid decline and dip at the end. And this might happen quite quickly, maybe over a number of days or weeks, really. The middle section is the more chronic diseases that we see on a regular basis, maybe heart failures, chronic chest diseases as well, when they may have more rapid frequent admissions, and they would have a bit of a rapid deterioration, but then they would have their treatment and then respond to that, but never get back to their usual kind of baseline level. So their trajectory is more of a slower downward spiral. And the one on the right, the green one, is patients who've got dementia that we see more frequently, obviously, now in hospital. And their decline is more a very slow and gradual decline in health. Sometimes we get called to review these patients that have had a bit of a rapid deterioration, but they do pick up and respond well to treatment, but things are obviously on the downward trajectory. So when we're talking about addressing symptoms that show that these patients are approaching end of life, we undertake this as a multidisciplinary decision-making process. We would consider how many admissions those patients have had in the last 12 months. Anything that's more than 3 or above serves as a bit of a red flag, really, to see that patients are having more frequent admissions, and this gives us the indication that things are in decline generally with their general health. We would look at their baseline function, how they were managing before they were admitted to hospital. Were things starting to change at that time? Were things deteriorating on more of a slow basis, or were they picking up rapidly and that's why they were admitted? We'd be looking at what their response to treatment was during this admission, whether they're having a good response, whether that's something we could just help to turn around and discharge home, or whether the response has been very limited and things are still deteriorating. And obviously we take into account patient preferences and the preferences of the families as well. So we'd establish and rule out any potential reversible causes, as I've mentioned. We'd look at check at recent bloods, any improvements after any treatment, or maybe identify any trends that are going on. We'd record any scans, and if they've got a cancer diagnosis, we'd go back and compare those with previous scans, and that might indicate that there might be more of a disease progression, and that's what's causing the deterioration in the condition. And we'd obviously look for signs and symptoms. These might be more frequent now, and that might be more of an indication that that patient is approaching end of life. So with the process of the multidisciplinary decision making, we always look to, at this stage, maybe take into account of those investigations and maybe blood tests, and maybe not as appropriate to do this if patients are rapidly deteriorating, especially at the end of life. We don't want to cause them more distress and discomfort by taking bloods, or maybe performing scans, or maybe OGDs and things like that. So we're looking at their best interests and what we feel is best for them at this time. So we'd use the knowledge then gained from these assessments from all the multidisciplinary team, obviously discussing with the patient and the family members. They've obviously got a say in this, in what's going to be happening and the decision making. And we determine whether, if the patient is nearing end of life, then what plans we need to be putting into place regarding that. Sometimes there could be a bit of a level of uncertainty and ambiguity about if the situation is, if patients are deteriorating and whether this is an end of life situation. So we would go to colleagues with a bit more experience than ourselves, maybe, and have a chat and go through bloods and scans and things and speak to family. So I'm just going to touch on briefly now about some of the physiological indications that you're obviously all aware of, but that we would pick up maybe the subtle changes that happen when patients are starting to deteriorate. So there's the chronic fatigue, reduced function and sleeping more. This sometimes is what the patients will tell us that they're starting to struggle with. They get more tired, they're not eating and drinking as well. They may be increases in pain symptoms. The diet is reduced. They might become more nauseous, and their bloods would be altering as well, worsening EGFR with their albumin decreasing. So those are the type of things that we might pick up weeks before death. Sorry. And then days before death, we'd look at subtle changes, as in hypertension, changes in body temperature, skin color can change. They may be sleeping more often, reduced bowel habit, and further decreased appetite and fluids as well. Sorry. Here we go. And then hours before death, we sometimes see what we call as a purple patch, when they might have that sudden burst of energy that lulls everyone into a bit of a false sense of security that things might be improving. I often find this is quite tricky for family members, when the patient might become more alert, have a bit more energy, want to have a drink, want to eat a meal. But obviously things do then deteriorate sometimes quite rapidly after this purple patch situation. So hours before death, then altered breathing habit, weak pulse, cold mottled skin. I think at this stage, as we do a bit previously, I suppose, is just having those conversations with families, what to expect at this time. Lots of family members haven't had any contact with patients approaching end of life previously, and to let them know that these things that are happening and the changes that we notice are normal, and that's what we would be expecting, because obviously it's a very scary and difficult situation for them. I've just got a couple of references here, but by all means I'll share these at the end if anybody wants to have any further information regarding this. And I'll just pass you on to Joe now, who's just going to discuss how we manage symptoms at the end of life.
Thank you, Andrea. Hi. So now that we've actually recognized that someone is in the last days or even hours of their life, now that we've recognized that actually there's nothing we can do to stop this deterioration, how do we actually manage the situation to ensure that the patient gets the best possible care, and also that their family and loved ones are well looked after as well? Because for the patient, it's a basic human right to have care at death, but also for the family, these are the memories that they are going to take forward with them following the death of their loved one, and can affect the grieving process. So what we don't want.
Sorry, Joe. Sorry.
It's okay.
Sorry.
What we don't want is a family going away from the hospital thinking, oh, my brother, my mother, my sister, or whoever were in pain. Nobody took any notice of them, and we were never sure what was going
Nina.
on. That's what we want to avoid. So what I want to do is actually have a look at the. Oh, sorry.
Sorry, I've interrupted everything. Sorry. Shall I stop? I stopped sharing that. Sorry. Sorry, Joe.
She likes to share, don't you? So what have I put that on there? No. What I want to do actually, while Nina helps me out, is I want to look at the care decisions guidance, the document that you're probably all very familiar with, but often only in the context that it needs to be signed before we can actually start the patient on SUSE, our symptom scale. No. Sorry, just having a few technical abilities. I think you can see my slides though, is that right?
I can see them, Joe,
Yeah,
but
I
they're
can
not.
see them.
You just need slideshow mode, probably.
Down there. Is that any good? Is it on there?
Yes, it is there.
Okay. Okay, so what I wanted to do is have a look at the care decisions guidance. So this is a document that, as I say, you're all familiar with probably, certainly if you work in the hospital, but you probably only know it as something that has to be signed by the doctors before we can actually stop regular observations and start our symptom early warning scale. So actually, this is a very useful document at the end of life, and it's a guide for all healthcare professionals who find themselves looking after someone in this position. So it's really something that should be looked at the beginning and not at the not as an afterthought, as it will guide us through the considerations that need to be made, the conversations that need to be had, and also how to actually manage the patient's care going forward. Some of the criticisms in the past about these end of life documents have been that healthcare professionals have made all the decisions without actually consulting the patient or the family. Obviously, these are very, very, very important decisions about the end of somebody's life, and this document seeks to address these problems. Have we got the slides or? Okay. Okay. So generally, the aims of the clinical the care decisions document is to deliver the best care possible to patients at the end of life, whatever the setting, to support healthcare professionals in decision making and planning care, and to ensure that patients, if possible, and all those important to them, are included in decision making, and to ensure that the patient's wishes and preferences are considered. So I can't go through the whole document. I'm sure you don't want to, but I'm just going to sort of pick out a few important bits before we go on to look at the symptom management. And also important to say that this document is regularly revised and updated, and just to make sure that you've actually got the right, what do you call this, the right edition, really. Yeah. So if you look on the first page of the care decisions document, it says it helps us to document actually, do the clinical team agree that the patient is in the last days of life, and how do they come to that conclusion? Have all the reversible causes of deterioration been considered? And then to look at the patient's understanding. Now, it's not always possible to include the patient in the discussions because sometimes they've deteriorated too quickly and they're not able to join in those discussions. But if it's not done with the patient, it should be done with their nearest and dearest. It also looks at any type of advanced care planning that might be in situ, certainly looking at the CPR, whether the DNA CPR has been completed, whether that's been discussed with the patient, and whether there is any advanced decision to refuse treatment or lasting power of attorney that might be important. Also, about tissue donation may be important in some cases. Then another one thing that I wanted to point out was actually that's always really important discussion to have with, particularly with the family, is about how we're going to go forward with nutrition and fluids. It's always a really contentious issue because, even if the patient is really unwell, they haven't got any appetite, they've got no interest in eating or drinking themselves, it's something that the family naturally wants to do, is to actually feed their relative, or give them fluids. And um, so they can find it very difficult if the patient hasn't got an intravenous line. So we need to actually have discussions around that, and talking about the pros and the cons of perhaps intravenous fluids, about really, do we want to inflict more sort of intervention on the patient by cannulating them. Um, Even if they have IV fluids, they've got a line there already. Can the can the intravenous fluids actually cause more damage, fluid on the chest, more edema? So those discussions need to be had with the family, as they find this often a very difficult part of the end of life phase, really. And obviously, at this point, as well, as to make sure that the patient has good oral care if they aren't eating and drinking. If you look at page 3, it actually recommends that nurses particularly look at page 3 on the care decisions document, because it has a lot to do with a nursing care plan, and it looks at monitoring, so of vital signs. So these are usually stopped so that the patient doesn't have to keep having their blood pressure taken, etc. Regular blood tests can be stopped. Monitoring blood sugar levels. What are we going to do about those if the patient is a diabetic? And there is a document to actually guide you through that as well. What are we going to do with often we stop all investigations, and actually to look at the actually how we look after the patient, which includes symptom management. So if there's one thing I want you to take away from this seminar today, really, is that to manage symptoms anytime, but importantly at the end of life, is to manage symptoms effectively. We need to assess the symptoms as well as treat them. It's like if you're trying to treat somebody's blood pressure, high blood pressure, you wouldn't treat their high blood pressure without recording their blood pressure on a regular basis. And if you're trying to treat their a high blood sugar, you're not going to treat it successfully without monitoring their blood sugar regularly. So to actually treat something successfully, you need to have regular assessment. And often as nurses, we're in the best position to actually assess a patient because we spend a lot of time. So when you're assessing someone's blood pressure, you can take a reading. That's easy enough. If you're monitoring someone's blood sugar, you can take a reading. Often symptoms are much more difficult to assess. It's much more of a subjective thing. But even though it's more difficult, it's very important to assess symptoms. So, for example, if you're assessing somebody's pain, it's very important to actually look at your patient history, know what is the underlying illness. So, where would you suspect the patient to have pain? I.e., if they have a brain tumor, you expect them to have a headache, perhaps, but also not the only the underlying illness that has brought them to this position, but also any other illnesses that they may have. So, for instance, if I see that somebody's got chronic back pain, or if somebody's got fibromyalgia, then that's a bit of a red flag, thinking that actually we're not only going to have to treat the patient's pain from the underlying disease, but also that they're going to probably suffer more pain, like back pain, because they are now immobile in bed. So we've got to think of those causes of pain, not just the underlying illness. We need to look at the location of pain because it may not be just one site, there can be multiple sites giving the patient pain. If the patient is able to still talk to us, what type of pain has the patient got? Is it a throbbing, aching, or is it a sort of shooting type of pain? Just to give us some idea of how we should treat this pain. And is the pain consistent or is it intermittent? What makes the pain better? What makes the pain worse? And actually, does the current medication that the patient is having, is it effective? Does it make the pain better? And if it does it for a short period of time, or does it just take the edge off the pain? So it's just to get a good understanding of that symptom rather than to just give a painkiller. It's like giving something in the dark. It's much better to get a good overall understanding of what that symptom is, and then you're much more likely to be able to control it. Obviously, when patients are at the end of life, often they can't, are too weak to speak to us. So then we have to look for other signs of pain, non-verbal signs of pain, such as grimacing, moaning, guarding, muscle rigidity, restless. So we have to take all these things into account. And then we can actually record them on our SOOS or patient symptom assessment chart. and it's a 4-scale chart where, or a 5-scale really, where 0 is no pain, 1 is mild, 2 is moderate, 3 is severe, and 4 is overwhelming. So anything which you would describe as 2, 3, or 4 should be treated. So if you're looking on the present edition of our patient symptom assessment chart, it will go through all the different symptoms, but it also leaves a couple of blank areas at the bottom where you can add in something like, as it suggests on the chart, if the patient is having seizures or if the patient needs regular wound care, you can actually make an assessment of that on the chart and individualized for that patient. The other thing about pain as well that's really important to assess is the pain may be okay when the patient is quietly lying in bed, but how is the pain when the patient is moved? So it's not good enough just to say the patient is comfortable at rest. The patient should be comfortable when they're moving as well. So actually, I thought, well, you could actually have pain at movement in one of these empty boxes at the bottom and record that separately, because I think that sometimes does get overlooked. So assessment is really important. Uh, we need to record the symptoms on the assessment chart. If you read, it does say required at least a daily assessment. That's for patients who are using this chart at home, and they might be visited by a district nurse perhaps once a day. In hospital, we'd expect the assessment to be made at least 2 hourly. So this is all in the care decisions guidance. So then it goes on to give you some guidance of how to manage pain with morphine in the last days of life. So morphine is our gold standard. That's what we always start with. Obviously, if the patient's already on some different analgesia, that will alter our management. But if the patient has previously not been on painkillers, morphine would be your drug of choice. And it shows you what to do if the patient is in pain or if the patient is not in pain. And even if the patient is not yet in pain, then we need to get anticipatory medicines prescribed in case, so we have it ready in case the patient does experience some pain during their final hours. And this flowchart gives you guidance over what to do if the patient can't take oral painkillers, about how to set up a syringe driver, or the dosages of subcut analgesia. Obviously, as I said, the patient may be on other types of painkiller anyway, which is going to alter your management slightly. But certainly, I think that's probably, if that is the case, then it's probably a good idea then to call in the palliative care team so we can actually help to manage the patient's care in that sort of situation. Breathlessness is a very common symptom that we come across at the end of life. It may be that the patient has got a disease such as COPD, so they're familiar with that feeling of breathlessness. It may be something new, but it's a very unpleasant symptom to experience. And this is where we actually use morphine quite frequently now, because morphine actually relieves the sensation of breathlessness. So it doesn't make the lungs better, it doesn't alter the breathlessness, but it does make the sensation easier for the patient. So it gives you ideas of what to prescribe. And also, breathlessness can be a bit of a vicious circle, because if breathlessness is unrelieved, then the patient becomes anxious, and the anxiety will then cause more breathlessness. So it may be that we need to use morphine to relieve the sensation of breathlessness, but also midazolam to actually relieve the anxiety and kind of break that vicious circle. Agitation and restlessness is also common in the last days of life. It may be that the patient is is just purely anxious, and that's obviously very understandable. And it may be that midazolam is a drug that is very effective. The patient may be delirious though, and may have sort of psychotic features such as hallucinations, confusion, and restlessness. And it may mean that we need to give them a drug such as haloperidol or levomepromazine, will actually work better than midazolam. So these flow charts, if you look at them, give you ideas on how to manage the patient's symptoms. Also important to note as well that actually and again, in assessment, try to assess why you think the patient may suddenly perhaps become agitated and restless. Is it because they've got uncontrolled pain? They may have a full bladder. Always something to look out for if the patient's not catheterized. Have they got a full rectum? Or is it just purely anxiety and fear? So try and get to know what the underlying cause is. And as I said, it's actually the nurse who's looking after the patient, who's spending the most time with them, who is most likely to make the best assessment of that. The management of noisy respiratory secretions, commonly known as my mother called it, the death rattle, when her father died. um, in the last days of life. Yes, it is quite common for people to develop noisy secretions when they're unable to swallow their own saliva, and it all gathers in the back of the throat. It sounds very alarming, and it's often worse for the family than it is for the patient. Um, and one of the things that we should do caring for that patient is to make sure that the family is reassured. The other thing we can do is to actually reposition the patient, because just by moving the patient, we can actually shift that fluid. Um, Sometimes we need drugs, and this flow chart gives you suggestions of the one that we commonly use, hyoscine hydrobromide, um, or occasionally glycopyrronium. There's not much difference in them. Um, but these are drugs that will help with that. But sometimes people suffer, just some secretions, other actually, do have a lot of secretions. I suppose depending on their underlying disease, really. And finally, nausea and vomiting in the last days of life. Actually, that's something I think really difficult to assess. But actually, unless the patient has got an obstruction or something like that, where it's more obvious why the patient uh, would have nausea and vomiting. It's good to know if you can think of why the patient might feel sick, because actually there are lots of different anti-sickness drugs, and some are more geared towards one cause than the other. So it gives us an idea of what is the best treatment for that type of nausea, rather than having to go through a number of different anti-sickness drugs until we actually find the right one. So all these drugs, we have to look at the actual drug itself, the route of administration, and to make sure that the patient gets the maximum effect. So these are the most common side effects or symptoms that people will suffer in the last days of life. And as I say, if the answer to these symptoms is no, the patient doesn't have them, we still need to make sure that the anticipatory medicines are written up just in case, and they don't suddenly happen in the middle of the night and there's nothing to give the patient. So we have to preempt that. So I'm going to hand back now to Andrea, and she's going to talk about communication.
Just going to try and find my slides. Sorry. Here we go. Here we go. It's just loading for you. Okay, can you see those? Yeah. Okay. So communication at the end of life obviously is something that needs to be done really with some lots of sorry, I've lost my train of thought now. So communication at the end of life is really vital, actually, to have good communication between the medical professionals and the patient and their relatives. So this slide just shows why good communication is vital, really, in all instances. So having difficult conversations may be raised really by the patient in your care. It might be the patient that might be quite well known to you, that you've looked after for a period of time and build up quite a good relationship and rapport. And that patient has started to identify that their condition might be deteriorating. Obviously, they recognise they're becoming increasingly weak, less mobile, and more symptomatic, and they are addressing the questions themselves, and they just feel more comfortable and maybe in a safe place with you around them to ask you these types of questions. How long have I got left to live? What will the end be like? Will I be in terrific pain? How will my family cope? How will my husband manage without me? And actually, am I dying? And it's really important that we answer these questions with care and dignity. Given the hospital setting, there are barriers, obviously, to effective communication with staff working on the wards at the present time. Workloads are really, really heavy, with time restrictions to having effective communication. The wards are really busy, there's poorly staffed, and staff may feel under pressure that they haven't got time to answer those questions. There's also a degree maybe of lack of knowledge or specific information that they're aware of about those questions that have been asked. They may feel that they've got a lack of experience and confidence really in answering those questions. Some people, it just really puts on the back foot and they don't know, where to start really. Inappropriate settings, like I mentioned, the really noisy environments that Joe's going to talk about in a little while, lack of privacy, those curtains don't really block anything out, even if you do pull them round totally. And it might be really inappropriate to have quite in-depth, difficult conversations with a patient, when the television's blaring, the radio's on and the buzzers are going. So it does make it a really tricky situation. Obviously language barriers, and then those patients might have poor hearing, have more sight, and these are all the type of things that we come across really on quite a regular basis. So some colleagues within the palliative care environment teams have come up with a Cardiff 6-point toolkit, which is really helpful to kind of ease yourselves into having these difficult conversations. And there's a number of factors that they've identified to help ensure that these conversations are had in a bit of a more of an appropriate manner really. So I think the first one regarding comfort is, like I've mentioned, have you got the time to have that discussion? Can you make the time to have that discussion? Those type of questions are not the ones that you can really walk away from without giving a really, really good and honest answer. Most importantly, is the patient comfortable at that time? Have they got any pain, or are they in any distress in any way? Are they uncomfortable in bed? It's important that they are comfortable, and then we can open up those conversations. As I've mentioned, privacy, if it's not in a quiet environment, is there any option of maybe moving them or taking them out to another area that might be a bit calmer, a bit quieter? So you've got a bit more privacy with less likely interruptions. It's really important to position yourself close to that patient, grab a chair, sit up close, good eye contact. And I think we all really need to be aware that if we are going to give that patient bad news, the bad news is bad news. It's not the fact that we, the patient, the person who's given it to them, that they're upset with. They're just more likely to be really upset at the news that you're giving them isn't the news that they want to really hear. And obviously, a lot of the time that's life changing for them. So language then, we need to consider our verbal and non-verbal communication, our body language and our eye contact, as I mentioned. 80% of the communication that we undertake is non-verbal. We need to consider their spoken language. Is a translator required? Are family members available to assist? Have we got anyone on the team that speaks, maybe they're Welsh speakers? We've got Welsh speaking CNSs on the team that we can ask to come along and assist us with that. Avoid any jargon, no slang words. We need to use clear and complicated explanations, words that are easy to understand. Always use the word cancer if that's what's happening, if that's what they've been diagnosed with. Um, some people might explain that as a lesion, or we found something nasty, or that there's a mass. I think it's important those patients, understand what actually they are being dealt with, really, unfortunately. Your tone of voice, gentle tone of voice. Don't rush the conversation or the explanation. Patients who are given a poor diagnosis or some information that they weren't expecting, I always think it's quite hard for them to comprehend and process what's being explained to them. So I think it's really important that we do it gently, take our time to explain, and really maintain good eye contact throughout. Questioning style then, as Joe said, assessment is key really in our line of work. We really need to find out those nitty-gritty things that are bothering them. So it's important that we use open questioning, how are you? How have you been over the weekend? How are you feeling? How are things with you at the moment? It's important we give time to answer those questions. Like I said, we're not rushing that patient. We need to make them aware that we've got time to listen and to take on board what they're saying. Avoid leading questions and avoid multiple questions at the same time. This is something that I really have to stop myself doing. I'm terrible. I just want to get in there and find out all of that information quickly. So I often have to pull myself back, let that patient answer before I go on to the next question. And it's avoiding to give lots of information at one time. Go at their pace, see how much they are dealing with at that time. It might be worth in the future coming back and giving them more information at a later date if that's what they're feeling like they can only cope with. Listening. This is really, really important. Good communication equates to 80 to 20 listening to talking. Silence is golden, as they say, and it is really good because we need to acknowledge that, as I've mentioned, that patient needs time to digest that information and process the information that you've given them, that those questions that they've asked, the answers that they're having, they're understanding. By using silence, we can also allow that patient to feel that they're more in control of that situation. Like I mentioned, we go at their own pace rather than keep on talking, and questioning them. They need to have that time to process things. And during this process, we'd use short words to encourage the dialogue, to acknowledge that we're still listening to them, such as, yes, I see, go on. Reflection. It's really important that we reflect back to them what they're saying. So if they're mentioning about their pain, we can, reflecting back that you mentioned your pain wasn't as good today, that type of thing. So it'll encourage them to continue with their discussion and maybe give us a bit more of that information that we might be looking for. It's understanding, it's for us to understand what they've understood by the information they've been given as well, for us to clarify that they're taking on board maybe what we're saying. This will also make them feel that they've been listened to, and it will help to develop that rapport between us, between the patient and nurse relationship, really. Make them feel that they can trust us, that we're listening to them. It'll also, reflection will also help us pick up on those keywords or cue words that they use, that we can then question further if we pick up on things. They mentioned that their pain might not be as bad, but it might be because I didn't take my painkillers until late, or things like that. Well, why wasn't it as bad? Why isn't it as good as what it could be? It's those little things that they might drop into the conversation that we know to pick up on. And then summarizing, this is really, really important because this is the time to clarify that patient understands what you've told them and what's been said. It gives them the opportunity to discuss anything further they might have missed, or maybe during that conversation, they've thought of something else they want to ask and they want to discuss. It gives us the opportunity to acknowledge the situation, to understand that it must be really difficult for them, that the information we've given them might be hard for them to process. And I think at this time as well, what I tend to do is to use that silence as well, just to give them that time to process what I've told them and what I discussed with them, to give them that opportunity to think things through for a little while, and then to maybe come back to me with further questions. At the end of this, it's really important that we plan for future discussions if they want them. They might want family members to come in and have a chat with us about things and plan a follow-up meeting as well. I've just got a little slide here about breaking bad news, just to give some kind of tips really about how we kind of go about breaking bad news in our field of work really, which can be quite tricky, as I mentioned. So I think it's really important to start off with determining what the patient already knows, what's their level of understanding, what have they been told previously and what do they understand by that. Have they got good insight into the situation? You know, have jargon words been used when they've been told previously? We need to clarify those and we need to reflect back to them as they're telling us. Quite importantly, what do they want to know? How much information do they actually want at that time? Do they want to know the full nitty-gritty? Or are they wanting to know just their scan results so they can process those, and then maybe further on they'll say that's as much as I can deal with at the moment, but I will need further discussions at a later time with you to discuss how this is going to affect me. It's really important that we give that little warning shot. Maybe things like, I'm really little worried about your scan results. I've got some concerns about what we found and I feel the situation is changing. A lot of the time when you clarify that, they will agree with you that they felt that the situation's changing, that they can see that things are not as good as what they were maybe days or even a week ago. As I mentioned earlier, it's really important that we break the news slowly, that we don't use any jargon, that we speak clearly and in a manner that they can understand and give them time to digest what they've been told. Allow that valuable silence again to give them time to absorb and react to what we've told them. And then make a plan, as I mentioned earlier, to have further discussions. If the family are not involved in that first discussion, arrange to meet the family, update them with what's been told, and obviously ask for any questions at that time. I've just done this last little slide really about communicating with families at the end of life. I've been involved with a really couple of difficult end of life situations over the weekend and the last couple of days. And I think our communications with the family have been really, really vital. One family in particular, very young children, and it was really quite a tricky situation, but it was vital that they knew, and actually they were questioning us whether they'd made those right decisions. So I think right at the end of life, when that patient maybe is less responsive and less aware of what was going on, you need to really provide them with lots of support, update them on a regular basis of any changes that's happening to the patient, whether it's subtle changes, if there's further deterioration, obviously any changes to any medications that we might be making to manage their symptoms more effectively. I think a lot of the time it's just us giving time to just sit and support them. Maybe just having a chat generally about things, but just for them to be aware that you are there to support them at this difficult time. I think it's really important that we answer all questions they have, like I've said there, to the best of your ability or your understanding. And if you can't answer those questions, that then maybe have a chat with somebody that might be able to help. Like ourselves in the palliative care team, we're more than happy to speak to family members on your behalf if things have become quite tricky and difficult. And maybe junior staff feel a bit out of their depth, but it's maybe taking them along to when you have that conversation to have those discussions so that they pick up on what's been said as well. And it's just for us to really acknowledge that we can't change the situation that they are going through at that time, but through our support, it might make things easier for them. So that's the end of my slides. I'm just going to pass through back to Jo now, and she's going to talk a bit about the environmental issues that we come across.
Can you see that slide, environmental issues?
I think we can still see Andrea's slides at the
All
moment.
right, okay.
Yeah.
There you go. Sorry, Joe.
That's okay.
Is it that one?
No, it's not that one. No. Let's do this a minute. No, I want to see. Should I do this? That. I'm sorry about this. We are complete novices.
No problem. Well, while you're just sorting yourself out, if anyone's got any questions for just at the end of the presentation, can you pop them in the chat, please? And I know that some people have put some stuff in the chat, which I will get to at the end. But anything else you want to know, or any comments, questions, feedback, pop it in the chat for me. Thanks.
Right, sorry about that. It's only one slide anyway, actually, but there you go. But actually, as Andrew was saying, I mean, communication is so important. And, you know, in a busy hospital, not so noisy, what a noisy place, you know, it's really difficult. One little thing I'd just like to add on to that is it's, you know, very important that the patient can hear you. And just to let you know that we actually have these temporary hearing devices. We've got some here in the office, in the palliative care team office, and you can also get them from the sort of hearing aid department. That if a patient, you know, isn't able to wear their hearing aids anymore, and they often don't like wearing their hearing aids, that you can actually use this gadget, and it just instantly improves their hearing. And I've had a couple of really good experiences with them when I had one chap who's at the end of life, and I gave him this gadget to try, and his son said to me, I wish I'd have had this gadget for the past 5 years, because what fantastic conversations we would have had. So, you know, they were having a good old chat, and that chap patient died a few days later. So they were able to communicate together, which was great. And another lady who was at the end of life, an older lady, her daughter was with her. I gave them the gadget, and the patient herself, she seemed quite sort of very sort of drowsy, lethargic, wasn't really interacting at all, as people don't when they can't hear. And I came back a couple of hours later, and they were watching the chase together on the TV. And it was just lovely to see them. And the daughter was thrilled, and she said, "It's, you know, it's like I'd have paid £1 million for this gadget." So just to let people know that there are temporary hearing devices with just like a little set of headphones, that the patient can wear, and it just, you know, it just helps that communication 100%. But yes, it's a very noisy, a very busy place, an acute hospital. You know, it's on the go 24/7. And even if it is the preferred place of death for a patient, you know, it's not really the best environment, is it really? So it's just having a little think about what 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 considerations that try to make that sort of environment just a little bit better. So obviously patient location is important. And as soon as you think about somebody at the end of life, you think about getting them a cubicle, because obviously a 9-bedded ward is not the best place to spend your last few hours, because of the constant activity, the noise, the lack of privacy. And also, it's not a good location for the family to visit, is it? So if you can get a cubicle, that's fantastic. But obviously, there aren't many cubicles on our wards here. There are only sort of 4 on each big ward, so there's not always a cubicle available. I suppose the other thing I thought of as well is actually that actually perhaps not everybody wants to be in a cubicle, because if you don't have friends and family to visit you all the time, you can feel pretty isolated because you're so weak you can't do anything for yourself. And if nobody comes in to see you very often, then you spend a lot of time on your own. So perhaps a nine-bedder is not the right area, or one of these Nightingale situation as we have in Landoc. But sometimes perhaps a cubicle isn't either, and perhaps just a smaller ward if possible. Obviously, trying to control elements like noise, light, and temperature. The trouble with the cubicles is they're right behind the nurses' station, so they can be a very noisy place. Um, Also, to think about the lighting, the harsh overhead lighting, and also about the temperature. Oh, the other thing about lighting is a lot of the cubicles don't actually have curtains in. And I don't think we'd be able to get a peaceful night's sleep at home if the overhead light was on all night and the curtains hadn't been closed. So it's just thinking about things like that. So actually, it's probably not the best time to think about getting curtains for your cubicle, because it might be too late then. But actually, we need to look at that on the wards to make sure that all cubicles have curtains. Another example that I had is when I had a lady who was dying and she had two really, really caring sons. She was in a cubicle, but they were really upset because there were no curtains there. So I actually got some old curtains from home, and I went and took the curtains, put them in the room with the idea that I would go back later and try and hang them myself. And by the time I got back there, the sons had already hung the curtains up. So they really appreciated that. So I'm not saying that you should all go home and get your old curtains, but sometimes you have to think outside the box, really. Temperature is a very difficult thing to control in this hospital, certainly. But if we can't control the temperature in the room, perhaps we can actually just think about blankets for the patient, or maybe the patient's too hot, looking for signs which may indicate that the patient is too warm. Um, and that's another leads me on to really to invite the family to personalize the room if the patient wishes. So if the family want to bring blankets in, if they want to bring pillows in, it just makes the room look less clinical. And also to remove any equipment that's not being used. So it's just thinking about little things like that. um, I know everyone's really good, and families are allowed to come and go um, at the end of life. Um, so I also thought about pets, and I had a really sort of warming experience on one of the wards where this chap he didn't have any friends or family, but he did have a pet dog. And he really wanted to see his pet dog before he died. And one of the staff nurses actually went to, I think it was in like a rescue center. Is that where you keep a dog? Yeah. Uh, because obviously he couldn't look after it. So she went and collected the dog and brought the dog into the ward. And actually the patient died a few hours later after seeing his dog. So, that's just making the environment a bit better, isn't it? Um, if the family want to stay, offer them a portable bed. We have portable beds here and in Landoc, and it's certainly a lot more comfortable than trying to sleep on a chair. Because often we have lots of elderly patients and they have elderly spouses. So, it's not great for them to stay sitting in chairs. Um, and the other problem is it's just about making everybody else on the ward aware what's going on to avoid unnecessary interruptions. And I'm sure we've all come across situations where, somebody's, barged into the room, the phlebotomist or the caterer, unnecessarily and at the wrong time. So what we're trying to do here to try and avoid those sort of or to help avoid those situations is we're looking at implementing a a symbol, a symbol that will be recognized by everybody, as it will actually, so the symbol will be to state that the person in that room or behind those curtains is actually at the end of life. So hopefully that will try and avoid some of the unnecessary interruptions. And it's not an idea that we've had ourselves, but it's certainly used in North Wales and in England successfully. Just I'm not sure how then, just like a poster type of a symbol on a poster that you can actually just put on the door so everybody knows that not to barge in or actually to be quiet in that area. It's just to show respect to the family and to the patient themselves. So I'm sure you've had a lot of those thoughts yourself, but it's just something to consider to try and make the environment a bit better. So I'm just aware of the time now. So I think we're going to finish now, and we'll answer hopefully any questions that you have, or try to. Thanks for listening.
Thank you so much, Joe and Andrea. So hope there is loads and loads of information there, which I'm sure will be really helpful to lots of the people on the call. And as I said, this will have been recorded for anybody that wants to look over things again. So there's quite a few comments on the chat. I'm just going to pick out some and not necessarily take them in order, but I will try and get to them if that's okay. So, question from Kay Ryan. How well equipped do you feel the ward staff and medics are to have discussions and to care for people at end of life, or do they always call the palliative care team?
I think it's a knee-jerk reaction to call the palliative care team. I think often they've done a good job themselves, but they haven't got the confidence to see it through. I think if you actually use the care decisions document properly and at the beginning rather than as an afterthought, as I said, that would give them a better sort of guide and perhaps give them the confidence that they're actually doing the right thing. I don't know what you think, Andrea.
I think the same. I think there are some obviously junior staff on the ward that wouldn't feel confident to have those discussions. So that's maybe at those times that they would call us. But I think the majority of the time, information is relayed really quite well.
And do you think if people had more time to come with you guys when you're talking to people, Joe and Andrea, that they might be able to learn by sort of role modeling type thing? Because I know that nursing and medical staff do get some training in communication skills, but it's unless you put that into practice straight away, it can be difficult to change the way you deal with things, doesn't it?
Yeah.
Absolutely. I mean, role modeling is the best way to learn,
Yeah.
but it's just having the time to do that, isn't it, really?
I think in an ideal world, we could, we can involve the staff on the ward to come with us all the time. But like Joe said, they're usually so stretched with dealing with the other patient care they've got on that it's very rare that they do come along with us to have those discussions. But perhaps that's something that
But
we should be considering as well as a team, maybe to
and
be
they're always
encouraging that a bit
invited as
more.
well. That's the
Yeah,
important. They're
yeah,
always welcome to come along with us.
yeah.
And actually, as I said about when you're talking about assessment, it's the staff on the ward that know the patient the best. We only get a snapshot of patients. It's actually the people who are spending the most time with the patient that are in the best place to tell us about symptoms and how the patient is feeling. So their role, their impression is really vital. So it would be better if they always came along with us, really, in an ideal world.
Agree, and that's a little bit along the lines of what Kelly Snowden is saying, who's from Betsy, but a recent sort of new acute ANP in medicine, and just saying that presume it's she, Kelly, has witnessed sort of good and also some bad communication there from medics, and was just wondering what learning they have about breaking bad news and things.
I
Um,
know I spoke to an F1 yesterday or Sunday, and actually she'd done a really good job at, talking to the patient and the family. But she said to me, I don't know what I'm doing. I don't remember having any teaching in my training except for one lecture. So again, she lacked the confidence. She had the skills, but she actually lacked the confidence. But yeah, I don't think there's a lot. It takes more than one lecture, doesn't it, to to gain the skills.
Yeah,
Yeah, and that's why the role modeling and stuff is so important, isn't it?
Yeah.
Because you are not going to remember in a stressful situation something that you did in medical school or during your nurse training 3 years ago or whatever,
No.
are you?
Yeah, exactly.
Yeah. Okay, so Eleanor Landeg is a speech and language therapist working in UHW in neuro-oncology and AOS, and has been involved with caring for patients towards the end of their life, and is asking, have you got experience of working with speech and language therapists in end of life care situations? And if not, what sort of support and information would you like to receive? Because I think Eleanor would be keen to become involved or to develop a service from speech and language to patients at end of life. Do you want to comment on that at all?
Well, I think it's the most I've ever come into contact with speech and language therapists is in this job. And what I will say is they have very good documentation. So when they assess somebody, it's all written down in the notes, and that's really, really helpful. That's really helpful. It's all very clear. They have the recommendations, so that does help a lot. And often documentation is very poor, but theirs is usually very good. I would say that.
Yeah, and I think we have lots of input from speech and language in terms of assessing swallow and that sort of
Yeah.
thing, don't we?
Yes,
Yeah.
we do.
But
Yeah.
I'm aware that there's so much more that they can do in terms of communication and things for people with, neurological deficits. And yeah, it would be interesting to try to develop a service. Well, by all means, get in touch, Eleanor.
Yeah,
Yeah,
absolutely.
definitely.
Yeah.
Definitely.
And Kay is saying that she's had quite a bit of involvement with speech and language in supporting patients with MND at end of life. Okay, just let me see if we've got, so bear with me a second while I read the rest of the messages. While I do that, does anybody want to ask any questions? We can unmute you if you would like to speak. Or are there any comments from Andrea, from Joe, or from Fiona, who's still on the call, I think?
I'm still on the call, yes. I'm listening and thinking. Come back to me in a minute.
Okay.
Great session so far. Thank you.
It's a comment from Eleanor there, who's book by Catherine Mannix called Listen, which is about difficult conversations, and she has written several books, and I am trying to remember the title of the first one, which is about dying.
With the end in mind.
With the end
That's
in
Yes,
right.
mind.
that's it.
That's
Yeah,
right.
That's it.
that's right.
I've
Yeah.
listened to that one.
Particularly good.
So she's a really experienced palliative care consultant that's worked in lots of settings and has written really articulately about, the work that we all do. And there's a comment here from Rachel. So fantastic session, works in care of the elderly in CTM. Working to develop a symbol to use on the ward. And really appreciates the opportunity to attend the seminar, given her lots of food for thought. Would you recommend when breaking this news to bring families in, and how would you frame this when asking them to come in?
I think we usually do try and get families
Yeah.
involved if we know we're going to be breaking bad
Definitely.
news. Definitely, unless obviously the patient wants to be told on their own. And I think we would just use that little warning shot that maybe, I think it's quite difficult when families get a call from palliative care. Let's be honest about this. That we introduce ourselves as a palliative care specialist nurse or whatever, and we're involved in care. That just brings up the situation that they possibly don't want to be in, but having those conversations with them around them, and it's like I've said, it's about determining what they're already being told and how much information they want. But it's just we always try and get a quieter area to speak to them in, with the patient on board as well. But I think it's just imperative the families are involved as soon as we possibly can be, really. Is there anything else, Joe, you could think?
No, I agree. Yeah.
Yeah, I would say up to
It's
patients, I
something.
guess,
I think
isn't it?
I think we're very sensitive about, when we communicate with people.
Yeah.
And we know that actually, some people just fear those two words, palliative care. And you have to approach every person differently, because actually some people seem fine about welcoming us on board, others not, but we just have to tread very lightly.
And I would agree with Andrea there, saying, we need to have a chat about the future or where we've got to so far, how things are going. Is there anyone else that you'd like to be there? When will your family be visiting? Serves as a warning shot for people that this is a conversation that's important, and so then they can have a think about who they want there or who they don't really.
And we're actually, we were saying now that COVID is over and all the families are back in the hospital, our kind of work has doubled because half of our work is about talking to the families as well. So that just shows you how much time we spend talking to families, because our workload is much bigger now. During COVID, it was it was just purely really
completely
about
dropped
talking to
off.
patients and making phone calls, but this is different,
Thank you. So just have a think if there's anybody that wants to ask anything else before we go. And Charlotte has put the feedback and evaluation link in the chat there. So please fill that in, because lots of people have very kindly said that this was a really helpful session. But if we wanted to consider, say this nicely to Andrea and Joe, if we wanted to consider doing any more ever, then we need to gather some
I think we need
evidence
to
about what
share
helps
amongst the
and what didn't.
team, Joe, actually.
Yeah, absolutely.
Oh my gosh.
So thank you so much to Joe and Andrea, who are really experienced teachers, but this is a slightly new platform and new technique. So thanks, guys, for doing
sorry
that.
about all the glitches.
Yeah, sorry about the hitches. Yeah, technical.
But it's just real life, isn't it, anyway?
Absolutely.
And thank